Good day. Welcome to RNA series 19. RNA series is nothing but random questions in neurology and neurosurgery with answers by myself, that is Dr. K Gireesh, physician, neurophysician and neurosurgeon. This is to benefit the practitioners of neuroscience and medical field for a lifelong learning and also for public awareness. The question which I am going to address in this session is, what is Gerstman syndrome? The Gerstman syndrome is found in the dominant parietal lobe lesions. Clinical findings include acalculia, agraphia, right to left confusion and finger agnosia. This was described in 1924 by the Austrian neuroscientist Joseph Gerstman in a very rare neurological disorders which is observed by him in a few patients, consisting of a tetrad of symptoms, an impairment in performing calculations, acalculia, discriminating their own fingers, finger agnosia, writing by hands, agraphia, and distinguishing the left from the right, that is left-right disorientation. This has been well described in the Journal of History of Neurosciences. And Zeidman has written an article, With a Smile Through Tears, the uprooted career of the man behind Gerstman syndrome, and he has narrated this in that. This syndrome is also described in normal, apparently but brain damaged children who present with a learning disability, where it's called developmental Gerstman syndrome as reported by P. Binto in the developmental Gerstman in Archives of Neurology 1988. Gerstman syndrome is caused by a specific brain lesion which affects the posterior lobule of the parietal lobe in the dominant hemisphere. If it is left, it is you. In about 80% of people, the dominant hemisphere is the left. So, left parietal lobule. It is usually on the left hemisphere, but in some patients, it could be on the right too. Especially the angular gyrus and the adjacent structures at the confluence of the parietal, temporal and occipital. That is where it gets affected. Some studies also showed that it is caused not only by a lesion as mentioned area in the parietal area, but also in the left middle frontal lobe of the dominant hemisphere. This was described very well as an article that has been published in one of a Japanese center called Shinjugaku and by Ando Y, Sawada M et al. Gerstman syndrome with a cerebral infarct in the left middle frontal gyrus. A rare one, which has been published in the literature. The causes of this syndrome may be ischemic stroke is one. Tumors can in fact produce presenting with Gerstman syndrome. Carotid artery dissecting or dissecting aneurysm of stenosis, described by Kurata et al. And Oka H et al. And published in the Journal of Neurosurgery in the year 2003, December 1999. The other cause can even be a middle cerebral artery aneurysm can in fact produce this. Progressive multifocal leukoencephalopathy can in fact produce this. There also is an interesting publication that chronic subdural hematoma can in fact present these features, like Okumura, published in the Journal of Brain in 1998, a patient Gerstman syndrome associated with chronic subdural hematoma. Multiple sclerosis can in fact produce this, a demyelinating lesion can present with Gerstman syndrome. Posterior cortical atrophy, there have been 2 case reports published in the Clinical Neurology Neurosurgery of 2001, July 2003. And other diffuse etiologies like alcoholism, carbon monoxide poisoning, lead intoxication, anaphylactic shock, systemic lupus erythematosus and vasculitis can in fact produce, which represents with Gerstman syndrome. And sometimes it may be a cystic lesion within the dilated perivascular spaces which produces it. And there has been a case where it's a complication of a cerebral angiography. It has been presented, and it is also can be presented as a complication of a contrast which is used in angiography, as a complication of the endovascular treatment of dural AVMs, posterior leukoencephalopathy syndrome, necrotizing granulomatous inflammation of small, medium-sized and subarachnoid vessels, adverse drug reaction of acetazolamide and embolism from the left atrial myxoma. Now, acetazolamide, there is an article that has already been published in the Journal of Clinical Practice by Lee et al. Acetazolamide induced the Gerstman syndrome. So, therefore, the causes of this syndrome may be from ischemic stroke, tumors, carotid artery dissecting aneurysm or stenosis, middle cerebral artery aneurysm, progressive multifocal leukoencephalopathy, chronic subdural hematoma, multiple sclerosis, cortical atrophy. Other diffuse etiologies are alcoholism, carbon monoxide poisoning, lead intoxication, anaphylactic shock, systemic lupus erythematosus. Rarer causes are those. Now, what is the mechanism? Several authors have suggested that there is the defect which causes some of these symptoms like acalculia, right to left disorientation, and the finger agnosia of this syndrome is the mental spatial rotations. It is thought that the problem in this syndrome is in restricting the degrees, the freedom of spatial rotation, especially defective horizontal mapping, as published in the Journal of Cortex in 1995 by Gold M. et al. The right-left confusion in Gerstman syndrome, a model of the body-centered spatial orientation. Now, it is also thought that the pure form of Gerstman syndrome is caused by disconnection from a subcortical parietal white matter lesion which affect the crossing fiber tracts and disconnects the separate cortical networks. This is also another that has been published by Abdelia et al. A proposed reinterpretation of Gerstman syndrome published in the Archives of Clinical Neuropsychology, 2040. Now, at the bedside, how do you diagnose finger agnosia, acalculia, agraphia, right to left disorientation? So, it is very brief. I can actually tell that. Inability to distinguish, that is finger agnosia, is inability to distinguish or identify individual fingers, either one zone or those of others. Now, here the examiner should cover the patient's eyes and ask him to stretch his fingers. Then the examiner should touch the patient's fingers lightly, and the patient should respond by identifying the finger as soon as it was touched. This examination should be done firstly with opened eyes to eliminate misunderstanding or lack of alertness. This test may be affected if the patient has a tactile insensitivity. A minimum of 20% false recognition by the patient is needed to diagnose the patient with finger agnosia. So, this is the mechanism, or this is way how we have to identify or diagnose finger agnosia. Left-right disorientation, that is difficulty in distinguishing between the left and the right sides of the body. The physician should give the patient a card with a written instruction like place the left hand to the right ear or a right hand to the left ear, any one such instruction, and the patient should be asked to read it loudly. If the patient read it incorrectly, the physician should contact with the patient verbally, and then the patient should be asked to do a similar instruction. So, this is how left to right disorientation is being tested at the bedside. Agraphia or dysgraphia, difficulty in which is not due to a lack of motor control, but rather inability to form letters or words correctly. The physician should show a clock to the patient. and the patient should write the name of it without saying anything about it. Firstly, then physician should show a word 7, S-E-V-E-N, to the patient. And after having read it and presenting it orally, the patient should be asked to write it. Then the patient should repeat the sentence. Suppose anything you can tell, like he shouted the warning, and then should explain it and write it, what that sentence means. So these are the ways to test agraphia or dysgraphia. And lastly is acalculia or dyscalculia. Difficulty with mathematical calculations, including simple arithmetic operations. A patient should be given a card which has the simple equation written on it, 85 minus 27 or 90 minus 25, and he should be asked to write it and calculate it. Then the patient should be asked to do a multiplying equation in his head without writing it or seeing it. So these are the ways to bring out the acalculia or the dyscalculia feature of the Gerstman syndrome. Therefore, the Gerstman syndrome predominantly occurs as a result of a specific lesion in the dominant parietal lobe that is usually around 70 to 80%, it is on the left side. The clinical findings include acalculia, agraphia, left-right or right-left confusion, and finger agnosia. Thank you very much.